Hello, friends. Once again, a very warm welcome to the group. And we had posted quite a few questions. So I'll try and take one at a time so that you're able to remember, understand, and more importantly, learn the right way. There was this lady who was 30-year-old. She was 30-year-old lady who had an history of, she was treated for acute appendicitis, and subsequently she formed a lump. So we need to understand first of all how does a lump form, and then once the lump is formed, what happens next. If you have a patient presenting as a lump only, appendicular lump, we put the patient usually on expectant treatment, which is, like I explained earlier, which is not the conservative treatment. It is an expectant treatment, which means you will keep the patient orally, IV fluids, antibiotics under observation, and whenever required, you may operate. And this regime is called as Oshner-Sherin regime. Right? So you may abandon this regime as and when you realize the lump is expanding in size, or patient has got high-grade fever, swinging temperatures, and pelvic diarrhea, which is due to pelvic abscess irritating the rectum, or if the patient is getting better. So if the lump is resolving, we may abandon it. If the lump is worsening, what can go wrong with the lump? That is appendicular lump. It can become an abscess, or it can perforate, or it can produce what is called as pelvic peritonitis, right? So all these features together. So naturally, in this case, the patient had a satisfactory recovery. That's why patient could be discharged after Oshner-Sherin regime to be operated after 4 to 6 weeks by a procedure that's called as interval appendicectomy, because there is a interval when you don't do anything. Interval appendicectomy. Now this 4 to 6 weeks period is enough for the factors that make it a difficult surgery in the first attempt, that is when there is a lump, difficult. That is, how does a lump form actually? Appendicular lump is appendix plus bowel plus omentum, and all getting mucked up together. So at the time of a lump, if you operate, there is a likelihood of complications or perforations, etc. So now this patient was in for interval appendicectomy. That is to just explain the background of what actually happens. Now I can also take a detour and explain as to how does it happen. Appendicitis will go through various stages. This is cecum, and suppose this is appendix, which has got a lumen lining. So let's take just the appendix at a time. Now appendix has got a broad base in children. That's why we don't get appendicitis commonly in children. So it is essentially an obstructive disorder, although there is also an ulcerative type where you don't have obstruction per se. An usual cause of obstruction in most appendicitis is uh, fecolith, which blocks here. So once that happens, the lining is mucosa. There's a lot of mucus that is secreted inside. And if we don't operate or we don't get rid of this obstruction, this would kind of balloon out in the form of this being blocked, full of mucus. So we call it mucocele. We still don't do anything. The walls get, the vessels are going in the wall only, and the appendicular artery is an end artery. All these factors together lead to infection here, which leads to formation of pus inside. And this mucocele changes into pus, and finally it may perforate and still remain contained within, say, the omentum, bowel, everything together, and that forms an appendicular abscess. But the perforation can also produce peritonitis, which has got a high morbidity and mortality. Abscess also is one indication for abandoning the osteal sharing regime because you need to drain it. And we have discussed it, we use muscle cutting incision to drain it. And finally, we do a retroperitoneal drainage by putting the finger behind and not opening the peritoneum and draining the pus and leaving the drain there. And in the same sitting, we don't do appendicectomy, which is what probably is understandable now. Now that's about the steps. First, the obstruction. So when there is obstruction, patient may have colicky pain, which is classically a pain around umbilicus that gets referred to the right iliac fossa. We have discussed it in acute abdomen. That if you don't still relieve it, it gets into a mucocele which can become pus filled and it can rupture. So far so good. If it ruptures into the peritoneal cavity, if it ruptures within a contained space by omentum, then it becomes an appendicular abscess. But if it ruptures into the peritoneal cavity, it will form a pelvic peritonitis, which will have classically pelvic abscess. I'll finish the matter here only. Will be in a patient with appendicitis, you have patient with swinging pyrexia, actually a sick patient with pelvic diarrhea. Then pelvic diarrhea is also called as false or spurious diarrhea. It's by irritation of rectum that it kind of initiates the passage of mucus. It's not a true diarrhea. Now, what are the two important steps that you should take in these cases? One is do a DRE. If you do a DRE, you'll find bogginess in rectovesical pouch in a male or pouch of Douglas in a female. The other thing is you must get an ultrasound done. That will confirm your diagnosis. It's a pelvic abscess. Pelvic abscess can be drained per rectally also, but these days we do ultrasound drainage. That's bladder, that's pubic bone, and that's the vertebral, that's the spine, that's rectum. I'm just drawing a cross section. You all been taught this during your first year. And the peritoneal reflection is like this. And that's the interior wall of the abdomen. This is the fascia of Denon-Villiers, and this is rectum, this is bladder. That's why when a lot of people say that when you're doing APR, you're going between wind and water. That's a plane, and this is a perineal body. The collection is here. If I can get a red color to show that. The collection is all here. So when you do a DRE, you can feel it. So you can do an ultrasound aspiration, you can do, or you can drain through the rectum. We have done it in the past. And this would be prostate here in a male. Now you can drain it through this route. In a female, you'll have uterus in between, which will be, say, if you take just the bladder part, I'm making a quick picture. Spine, that's rectum, and then there is uterus and there is bladder in between. That's the pouch of Douglas here. So you can drain it through the fornix also. So there are options to drain it, right? Now, if you really look at it from the point of view of patient, there will be a bogginess here into the rectum, and the patient may also have high grade temperature, swinging pyrexia as I mentioned, and pelvic diarrhea is due to irritation. The rectum will be irritated, and so patient will have false diarrhea, that is mucus will come out. So this is how it actually would be in case of pelvic abscess. You can do an ultrasound guided aspiration, which is what we practice these days. The per rectal or digital rectal drainage is also a method of drainage. Let's move on. So we got this uh, patient managed by Oshner Sharon regime and patient having recovered. Now taken up for appendicectomy, and you can actually see that there is a big appendix with some bit of, if I can draw it here, you obviously have seen the picture. Some part is narrow and normal, and this is the part which is bulging. Remember, any appendicectomy that you do, the specimen must be examined carefully and should be slit in cases of any doubtful lesion. Like there can be a tumor that is carcinoid tumor, there can be adenocarcinoma. The malignancy has to be excluded, that's what I'm trying to say. And when you slit it open, and if you find that there is a carcinoid like tumor and it is confined to the tip, which they say less than 1 centimeter in size and more than 1 centimeter away from the base, you can just do appendicectomy, and ideally you should send it for this end for frozen, so that you can actually exclude that the margin should not be positive. Meanwhile, this patient or any patient where you have a doubt about the appearance, it can be a malignancy also. Suppose, like you see, it is extending right down to the base. The base is narrow. You're still clear that this is not diseased by and large, but it is safer always to stick to this 1 by 1 rule. If it is it's nearer than 1 centimeter, you need to do right hemicolectomy. And this is the time when, if you're doing it laparoscopically, it becomes easier because you can actually look at the liver for metastasis. Appendix is a very common site for carcinoids. But carcinoids from ileum and bronchus are more commonly associated with carcinoid syndrome. Pardon the handwriting once again. So you need to have a look at the liver, you need to examine the patient, investigate for all the associated features. But mandatorily, all these lesions after appendicectomy should be slit open to see if there is a growth. The possibilities are many. It could be an appendicular, which a lot of you have written, mucocele. I've already explained to you what it is. The risk of appendicular mucocele, which again is beautifully answered by Naveen and also by Rishabh and a couple of other students, where we find that if it ruptures, then it can produce what is called Pseudomyxoma, peritonei, which needs very aggressive management, and we will discuss this scenario also some other time. Now, mucocele of appendix should be also should be treated by surgery. But once again I am reinforcing, always look by slitting the specimen as to whether you've got a clear margin or not. If the patient has got, now when you got a specimen, it goes for histopathological examination and also for immunohistochemistry to actually make a diagnosis. If it is an adenocarcinoma, taking all the possibilities. So mucocele of the appendix, you've done appendicectomy and be happy about it. If it is carcinoid, again appendicectomy if the margin is more than 1 centimeter away and it's more than 1 centimeter away from the base. But if it's close to the base, you can always take a part of the cecum, a chunk. But adenocarcinoma is a different ball game altogether. Invariably, the patient will have to be treated by right hemicolectomy plus lymph node dissection. So the approach to the case would depend on what exactly is the histology, but our attitude would be, more importantly, erring towards treating it as malignant rather than otherwise. So the first possibility we looked at was appendicular mucocele, but carcinoid, which again, as I mentioned, 1-1. Otherwise, you can take a cecal wall to be on the safe side, but preferably if it is less than 1 centimeter, right hemicolectomy. If it's an adenocarcinoma, then of course we do treat it like a cancer. So what do we do in that case? We do hemicolectomy. Now what would that involve? I'll complete that also. That is cecum, that's ascending colon, that's transverse colon, that's descending colon, that's sigmoid, and that's rectum. That's appendix. The concept is not based on length as you people are taught. Classically you would hear this is ileum. The last 8 centimeters of ileum, the ileocolic artery supplies like this, ileal colic, and it gives up a branch to the that's appendicular artery. Okay, now colic, ileal. There is a window here, which sort of this window here would be relatively less vascular. Therefore, we take out some bit of ileum also, which is in this case say about 8 to 10 centimeters. Some people say 15 centimeter. It doesn't matter. After that, we just follow the blood supply. That is based on the pedicles. Right colic, middle colic, which divides into two, the right and left. So this is middle. So ileocolic, right colic, mid colic. Now if you stay, take 10 centimeters of the ileum, cecum, ascending colon, and in between the two branches of the middle colic, it's a classical right hemicolectomy. Now if we go beyond the left branch and we do lymph node dissections also, then it is extended or radical hemicolectomy along with the lymph node. So it's more to do with the blood supply than anything else. And here in classically this scenario, we will be doing the right hemicolectomy, which means taking out cecum, ascending colon, transverse colon, and a lot of you answer lateral 1/3 of the transverse colon. There's nothing like lateral 1/3. This is the ileum. We will rely on blood supply. I'm repeating it. This is supramesenteric artery, which is the artery of the midgut. The artery of the foregut is celiac axis, and of the hindgut inferior mesenteric. Now, where does the foregut change into midgut? At the level of ligament of Treitz, not second part of duodenum. That's a wrong answer. So, ligament of Treitz onwards, it's duodenojejunal junction. Beyond that, it's mostly supramesenteric. Supramesenteric gives off one branch. I'm repeating, iliac, colic, right colic, mid colic, which divides into two branches further. So, if you are staying up till here, it is classical conventional right hemicolectomy, and you take 10 centimeters of this, which I explained to you why, because this part is avascular. We need to make sure the blood supply is okay. Right? So, ileocolic, right colic, mid colic. Beyond that, the supply is by inferior mesenteric artery. That is left colic, sigmoidal branches, continues down as rectal artery, superior rectal artery. That's the other artery. So, that should take care of it. But importantly, the case was to highlight that any time you find a doubtful appendicular appearance following appendicectomy, the specimen should be slit open to confirm that it's not malignancy, because if it is malignancy, the treatment is more radical than just appendicectomy. For a carcinoid of the appendix, we remove the appendix. Only appendix if it is more than 1 centimeter away from the base. Naturally, the margin is clear then. But if it is towards the base, or if it is more than 1 centimeter in size, we do the right hemicolectomy, but we do a conventional right hemicolectomy. The extended or the radical right hemicolectomy is done in carcinoma of the ascending colon and transverse colon, where we go beyond the left branch of the middle colic artery. So that's about this case. I hope that is clear. In addition to that, carcinoid, if we find on histology and immunohistochemistry, then we need to get the patient worked up for what is called MEN syndrome. All the other parts of MEN1A, 1, 2A, 2B need to be investigated, and also you do immunohistochemistry. Besides that, you also do the ultrasound and high resolution ultrasound to look for liver metastasis, and the management is different for this condition, because you look for indole acetic acid, 5-hydroxytryptamine release. These patients may be having carcinoid syndrome, and they can behave with diarrhea, they can have diarrhea associated with it. So all that's a totally different discussion. But this case was essentially to know as to how does the appendicitis actually happen, and what is mucocele of appendix, why should mucocele of appendix should be treated in early to prevent pseudomyxoma peritonei. A word about pseudomyxoma peritonei. The largest series of Pseudomyxoma peritonei is presented by one gentleman called Sugarbacher, and according to him we should do radical peritonectomy, which we do, and I'll share with you at some point of time. Peritonectomy, and we treated by heated intraperitoneal chemotherapy, HIPEC, which is under pressure. Heated chemotherapy is supposed to penetrate, is expected to penetrate deeper into the peritoneum, because here you removed all the peritoneum that you can, because you can never get a complete R0. R0 means microscopic absence, there is no cancer there. But in total peritonectomy, it is not possible to do it. Therefore, we also provide intraperitoneal chemotherapy. Under pressure, it is heated, and it can penetrate into the peritoneum and raw surface much better, which also leads to higher toxicity. So one should be, because more gets absorbed into the system, and that can produce systemic toxicity. So that's another topic. But importantly, Pseudomyxoma peritonei is an entity where you find a jelly-like collection inside, and we'll try and put up a picture of one of my cases of Pseudomyxoma peritonei that we operated, and we'll put it up as a quiz and a question. So I think that should do it.